Hi. Of acyanotic heart diseases, we have already discussed atrial septal defect and ventricular septal defect in the previous video. So today we are going to discuss about patent ductus arteriosus. So to know what is patent ductus arteriosus, you should know what is ductus arteriosus. So what is ductus arteriosus? It is this tiny vessel what you're seeing over here, which is connecting your bifurcation of pulmonary artery to aorta, just distal to the left subclavian artery. So this ductus arteriosus takes the blood from your pulmonary artery to aorta during the fetal life. But once the baby is born, within 2 to 3 days after birth, there will be physiological closure of this ductus arteriosus by contraction of the musculature. Now, within 2 to 3 weeks, there will be anatomical closure of this ductus arteriosus by proliferation of the intima. So when it is not closed beyond this, then it is called as patent ductus arteriosus. So the main culprit which causes this patent ductus arteriosus is your prostaglandin E2. So it is found that the prostaglandin E2 keeps the ductus arteriosus patent. So coming on to the risk factors, preterm babies are more prone to have patent ductus arteriosus. Certain genetic disorders like your trisomy 13, 18, 21 is also associated with. When we talk about the maternal condition, maternal diabetes or maternal exposure to cocaine or maternal rubella infection, they also impose the baby to develop patent ductus arteriosus. So moving on to clinical features. So let us assume the schematic diagram where you have the right atrium, right ventricle, left ventricle. So here you have got the pulmonary artery, lungs, pulmonary vein opening into left atrium. You have the aorta which opens from the left ventricle. So connection between your aorta and pulmonary artery, you have the patent ductus arteriosus. So normally what happens is the pressure in the aorta is little high while compared with that of pulmonary artery. So therefore the blood will get shunted from aorta to pulmonary artery. So therefore there is left to right shunt. So this you all know. So there is shunting of blood from aorta to pulmonary artery. So what happens to the volume of blood in pulmonary artery? It increases. So if the volume in pulmonary artery increases, what will happen to the volume in lungs? That also increases. So what happens to the volume in pulmonary vein? That also increases, which now causes increase in the volume in your left atrium and increase in volume in your left ventricle and increase in volume in your aorta as well. So because of this increase in volume, what happens to your left atrium is it will undergo hypertrophy. Your left ventricle also will undergo hypertrophy. And when you talk about your aorta, the initial part is going to be dilated. So your aorta initial part will get dilated. So this is going to happen with your left atrium, your left ventricle and your aorta. So it is going to be enlarged. It is going to be hypertrophy, dilated. Now, when there is increase in the volume in your pulmonary artery undergoes changes like proliferation of the smooth muscles and obliterative changes, and therefore your pulmonary artery will develop pulmonary artery hypertension, which is very important. So it develops pulmonary artery hypertension. So because of this pulmonary artery hypertension, because the pressure over here is more, the pressure in the right ventricle is more, pressure in the right atrium becomes more. So therefore this also will undergo hypertrophy and dilation. So therefore people with patent ductus arteriosus can develop congestive cardiac failure. And second, when this pressure in the pulmonary artery is going to be too high, this will cause the reversal of shunting. So there will be reversal of shunting. So there will be right to left shunt. So it will be from pulmonary artery to aorta instead of from aorta to pulmonary artery. So therefore there will be right to left shunt. Now this right to left shunt is called as the Eisenmenger syndrome. So this is called as Eisenmenger syndrome. Now you know what happens with right to left shunt is the deoxygenated blood and the oxygenated blood are mixed. So therefore the oxygenation is going to reduce. So therefore it is like your deoxygenated blood which predominates. So this produces a state called hypoxia, and whenever there is hypoxia, there will be cyanosis and clubbing of the limbs. But what is peculiar with patent ductus arteriosus? Now here you can see with the reversal of the shunt, it is going into the descending aorta. So it goes into the descending aorta, not the ascending aorta. So because it is going to the descending aorta, you can see the cyanosis predominantly in the lower limb, and this is called as differential cyanosis. So it is called as differential cyanosis. This is very, very important. This is characteristic feature of your patent ductus arteriosus. Why? Because the shunting of the blood diverts the blood into your descending aorta. So therefore there can be cyanosis of your toes. So your upper limb is spared. So it is called as differential cyanosis. Now apart from this, the child can also develop infective endocarditis. So yes, so one they can develop is heart failure, second is right to left shunt or Eisenmenger syndrome, and third they can also be prone to develop infective endocarditis. Now because of this shunting which is going to be from your left to right, which is from your aorta to pulmonary artery, it is going to be present throughout the cardiac cycle. So therefore it is called as continuous machinery murmur. It is called as continuous machinery murmur. So the murmur you hear in your patent ductus arteriosus is continuous machinery murmur, as your aorta continuously shunts blood from your aorta into pulmonary artery, and this is present throughout the cardiac cycle. And this you can hear it better in the left upper sternal border just below your clavicle. So this is the predominant feature you can see with your patent ductus arteriosus. So one clinical feature we have already discussed is about the differential cyanosis. The second clinical feature we have discussed is about the continuous machinery murmur. So what are the other features you can find? So the other features will be your wide pulse pressure. So this is also very important. So you can find wide pulse pressure. And third, you can also find a prominent carotid pulse. You can also find a prominent carotid pulse. So that is also seen with patent ductus arteriosus. So you can see a prominent carotid pulse. Finally, you can have paradoxical splitting of your second heart sound. So there will be paradoxical splitting of second heart sound. So what is that? Now second heart sound has got two components, and you know that it is A2 and it is P2. You have A2 and you have P2. So what happens over here is, because the left ventricular volume is more, your aortic valve closes little later while compared with that of your pulmonary valve. So it becomes your P2 is heard first and then it is your A2. So which is called as paradoxical splitting of second heart sound. So this is also a characteristic feature which can be seen in your patent ductus arteriosus. So how do you diagnose these conditions? So first of all, yes, echocardiography will tell you about the size of the heart, about status of your left atrium, left ventricle, right atrium, right ventricle, about the size of the patent ductus arteriosus, and what is the valve state. So everything can be found using your echocardiography. And similarly, your pulmonary artery pressure can also be found using your echocardiography. Chest X-ray will tell you about the heart size, about your enlargement of the atria and the ventricles, and will also tell you about the vasculature of your pulmonary artery. So whether the vasculature is increased or not. And what happens to the aorta? So whether there is this aortic knuckle prominence, or what happens to the arch of aorta, that is found using chest X-ray. Now moving on to ECG. ECG will tell you if there is left ventricular hypertrophy, or if there are any deep Q waves in your left chest leads, or there are tall T waves, because these are features of your volume overloading of your left ventricle. So this can be found in your ECG. So coming on to treatment, so basically when we talk about the severity of patent ductus arteriosus, whenever the child has got the wide pulse pressure or there is going to be a large heart, it means that the severity is more. So when the severity is more, how you can treat it? So basically it is the surgical management. So surgical management is mainly with ligation, or you can do it with the transcatheter closure, which can be done using coils, buttons or plugs. Now apart from this, when we talk about the drugs that can be helpful if it is in preterm newborns, then you can prefer indomethacin. So what this indomethacin does is, it is going to inhibit your cyclooxygenase enzyme, so therefore it will decrease the prostaglandin. So when this is going to decrease, then obviously your ductus arteriosus is going to close. So therefore you can choose a drug called indomethacin. And surgical is by ligation. So to put this patent ductus arteriosus in a nutshell, patent ductus arteriosus is an acyanotic heart disease where you have left to right shunt. So over a period of years, the child can develop pulmonary artery hypertension within months after developing patent ductus arteriosus, and they can have left atrial, left ventricle, right atrial hypertrophy, and they can develop congestive cardiac failure. They can also be prone to develop infective endocarditis. When the severity of the pulmonary artery pressure is going to be more, then that is going to cause reversal of shunting, resulting in differential cyanosis, as the deoxygenated blood is shunted from your pulmonary artery to your descending aorta. So treatment is basically done with drugs like indomethacin and surgical ligation. So that completes discussion on patent ductus arteriosus. Thank you.